Hello everybody, welcome here at the Vitrolife Group Academy studio at ESHRE in Amsterdam. We have a very exciting program for you today. You can follow the program here on the side of the booth. Our first presenter today is Dr. Robert Mendola from the CCRM Group in New Jersey. He's going to talk a little bit about his work and the work that his group's done on the way that we do ESHRE. I'm not going to say more. I'll hand it over to you. Thank you.
All right, thank you very much. I first want to thank Vitrolife for having me part of their workshop this year at ESHRE. My talk today is titled, "Is it time we move away from the use of zwitteronic buffers during the ESHRE procedure?" Now, the priority of current IVF is to find the ideal culture system to provide the best chance of a healthy live birth. Now, embryo culture media has seen significant advancements in the past 3 decades, thanks in part to companies much like Vitrolife. Now, these ideal formulations have been devised through numerous biological research, but we must also focus on reducing the stress of IVF procedures to increase our chance of success. Now, the key parameters we always monitor in the lab, of course, are temperature, osmolality, oxygen content, and pH. Now, this talk is going to focus on the pH aspect, and pH can have significant impact on development. It can impact cellular metabolism, membrane potential, microtubule assembly and disassembly, and genetic disposition. Now, the biggest concern is at the M2 oocyte stage, and the reason being, these oocytes cannot regulate their intracellular pH until approximately 6 hours after fertilization. So that is due to deactivated sodium-hydrogen transporters, and so therefore they cannot alleviate acidosis. However, they do have limited bicarbonate chlorine exchangers to alleviate alkalosis. So they rely solely on their cumulus cells for intracellular pH regulation. Now, during the ESHRE procedure, we remove these cumulus cells, leaving a denuded oocyte, as you see in the picture here. Now, this is very susceptible to pH fluctuation. So therefore, the pH control of our surrounding media is critical at this stage of development. Now, zwitteronic buffers maintain pH in atmospheric conditions, and they can do so because of their molecular structure, the gain and release of free hydrogen ions in solution. Now, heaps and mops are the most common in IVF zwitteronic buffers. And as you can see here, their structure's different. And so therefore, they're going to have different impacts on molecular pathways. Now, you can also see here bicarbonate, which is a very simple structure, but it holds extreme importance because it is the physiological buffer of all mammals and provides numerous benefits to the cells. Now, heaps and mops provides no nutritional benefit to the cells, and in fact, they've been found to have significant impact on cellular function outside of pH control. Heaps and mops have been shown to inhibit protein transporters. They've been shown to inhibit connexin and gap junctions. They've been shown to interact with metal ions. They've been shown to form complexes with DNA and produce free radicals. Now, HEAPS itself has been shown to produce hydrogen peroxide as a cytotoxic byproduct. HEAPS is also shown to have a rise in intracellular pH of cultured cells as high as 7.85. And studies have shown that increase in intracellular pH causes a decrease in cohesin proteins such as SMC3, having direct correlation with increased abnormalities, chromosomal abnormalities, and increased aneuploidy. Now, HEAPS has also been found to increase lysosomal stress in cells. And lysosomes are very important for nutrient assessment and metabolic function, not just cellular degradation. So this could have significant impact on cellular development. And they found this in numerous mammalian cells, but it was most visible in the mouse macrophage cells. And the reason being because of the micropinocytosis, the engulfing of the surrounding HEAPS buffer into the cells. Now, this is a concern for our ESHRE procedure. And the question is, does the surrounding buffer influx into the oocyte upon piercing of membranes? And what kind of impact does that have on oocyte competence, embryo development, and clinical outcome? And that's the question we set out to answer. And this is our most recent publication in JARG. And what we looked at, we used confocal fluorescent microscopy to determine the influx of surrounding buffer into the oocyte. And we also used a transcriptome analysis using ultra-low RNA sequencing, where we determined the impact of select buffer influx on the oocyte transcriptome. So let's start. The confocal microscopy. So we used a fluorescent labeled dextran stain to determine influx of surrounding buffer into the oocyte. So we had oocytes in a culture drop containing this fluorescent stain at very low concentrations to make sure that we were not causing any of this results. So we pierced the oocytes. There was no injection. We pierced the oocytes in these culture drops with fluorescent stain and then used the confocal microscopy to determine if the surrounding buffer influx into the oocyte. And again, we had non-pierced oocytes as a control in these culture drops. And what we can see is, from the piercing, it allowed the influx of the surrounding fluorescent stain, surrounding buffer into the oocyte, as you can see in the upper pictures. The dextran stain's in red, and as you can see, red stain is found inside the oocyte. Now, in contrast, the non-pierced oocytes in all intact polar bodies did not allow influx of the stain because of the cell impermeability and intact membranes. So we wanted to make sure that we were not promoting this result from our piercing process. So we pierced oocytes in a routine culture drop and then moved it into the culture drop containing the fluorescent stain, and within 1 minute. And as you can see, all oocytes pierced and moved within 1 minute had influx of the stain. And this is important because it shows this influx is beyond technician control. So no matter how good you are at ESHRE, or how careful you are at ESHRE, it does not matter. The piercing of the oocytes allows for the osmotic adjustments to allow the influx into the oocyte. So we took it one step further. We wanted to see, okay, when did these oocytes reseal their membranes? And so we did this in different time intervals, and what we found was no influx after the 2-minute mark, which highly suggests that the oocytes reseal their membranes within 2 minutes. Now, that goes to show the resealing properties of the oocyte and allowing for ESHRE success, but it's also a concern because now the influx of these zwitteronic buffers are now sealed within inside the oocyte. And we all know what happens when we put zwitteronic buffer into a CO2 equilibrated chamber. The pH plummets. And this is a concern with our M2 oocytes because they cannot alleviate acidosis. So the impact of the buffer's influx was further analyzed in our transcriptome analysis. And we use ultra-low input RNA sequencing to determine the impact of select buffer influence on the oocyte transcriptome. So we had 4 cohorts, one being a non-pierced control, and then we had 10 oocytes in the bicarb, 10 in the MOPS, 10 in the heaps. And what we would do for each cohort, we would pierce the oocytes in the respective buffer and then return them to a CO2 equilibrated incubation. And we did this, the incubation, for 5 hours. And again, this was our time frame of interest because the M2 oocyte is most susceptible and cannot alleviate or self-regulate its intracellular pH. So after the 5 hours, we did the RNA extraction. I'm not going to go into the details of the methods. Again, I would have you refer to our paper for more descriptive details. But I want to go over the summary of our results. And what we saw was the differential gene expression changes revealed the impact of the piercing process on these oocytes, as well as select buffer influence on cellular mechanisms after influx into the oocyte. So when we compared the different buffers, we found that the bicarb and the MOPS had very similar differential gene expression changes. But they differed significantly to the heaps group, which kind of gave us the strong suggestion that heaps is having a different impact on the oocytes than these other 2 buffers. Now, our results showed significant decreased cytoskeletal transcripts in the pierced buffer cohorts, as you can see here. The blue is the control, orange is bicarb, gray is heaps, and yellow is MOPS. So numerous decreased cytoskeletal transcripts, which kind of shows the impact of the piercing process. We showed higher levels of embryo competency transcripts in the bicarbonate cohort, possibly suggesting an improved choice of the bicarbonate buffer. We showed increased levels of stress-induced transcripts in the heaps and MOPS cohorts, possibly suggesting an increased stress response. And we saw higher levels of transcripts suggesting increased oxidative and lysosomal stress in the heaps buffer cohort. And I'll have you look at the far right graph here. Again, the studies show increased stress response, lysosomal stress response, showing increased transcripts of LAMP1, and we're showing the same thing here in our study specifically in the HEAPS cohort. Now, HEAPS also showed numerous decreased chromosomal maintenance transcripts, which is a concern. We saw these transcripts for DNA damage checkpoint, sister chromatid segregation, cohesin complex protein. And the far right graph, I'll have you direct your attention, again, is the SMC3, where we show the studies show decreased levels of SMC3 have direct correlation with increased chromosomal abnormalities, increased aneuploidy. So this poses the question, does influx of HEAPS promote potential mitotic abnormalities? Well, we did a retrospective study showing that HEAPS had a higher mosaicism rate than MOPS. But again, there's limitations to this study because it's retrospective in nature. So we set out to do a sibling oocyte cohort study. And in good conscience, we could not use HEAPS because of our results. So we compared MOPS to bicarbonate buffer. And I'll refer you to, this is our study that was published in ESHRE as an abstract last year. And what we did in this study, we first looked at the pre-equilibrated bicarbonate buffer to reassure us that we can use bicarbonate buffer in atmospheric air and the time allowed for ICSI completion. And we can, and we showed that. And what we did also find was bicarbonate buffer was far superior to MOPS in the sibling oocyte cohort study. We had a higher fertilization rate, a lower abnormal FERT rate, higher usable blast rate per ICSI, and a lower mosaicism rate. So in conclusion, zoeteronic buffers have significant impact on cellular function outside of pH control. Now the primary concern is the ICSI procedure where we have influx of surrounding buffer into the oocyte. Now intracellular MOPS, but especially HEAPS, can have negative impacts on intrinsic biological mechanisms as revealed by our transcriptome changes. Now it's been interesting, but current biological research recommends the use of bicarbonate buffer to avoid the unwarranted effects of zoeteronic buffer in their assays. Well, if it's recommended in biological research, then it should be highly recommended in our IVF clinical application. Selecting bicarbonate may reduce imposed stress, therefore resulting in improved embryo development and improved clinical income. But thank you.
Thank you very much.
Thank you.
Really interesting work you've done there.
Thank you.
I think it's very interesting to note nowadays that a lot of clinics do a lot of ICSI procedures.
Yes.
I think especially in the groups where there's genetic testing involved. So this is really interesting work going forward.
Yes.
Do you see that clinics would easily take this up and make the switch?
Yes. So what we wanted to do is we wanted to show that you can use this bicarb in atmospheric air conditions. So everyone can use it, as long as you're conscious of the time and you move diligently to make sure your oocytes are not outside of the incubator at a certain time. But showing that kind of promotes this for everyone to use. You don't need the elaborate, isolates or chambers to kind of do your ICSI procedure. It's more of just a diligent, work, and we found much improved of our clinical results because of it.
I guess it's not just from a media point of view that you're using, but also the whole economics behind it. Like you say, you don't need a lot of equipment and infrastructure to actually doing it right.
Right.
And it's great that we are reviewing the procedures that we are doing and actually see where we can correct things and make things better for the embryologists, but also for the patients.
Right.
Listen, thank you very much.
Thank you.
And we invite you to stay on for the next presentation. We'll be in 15 minutes and we'll be ready here. Thank you.
Thank you. Thank you. Thank you very much. Thank you.
Hello everybody, welcome once again to the second session at the Vitrolife Group Academy studio. On our next session we will talk about the fast and the glorious when it comes to warming and vitrification. I have two esteemed gentlemen here with me today. We have Dr. Jürgen Lieberman, he's the Director of Laboratories at the Fertility Centers of Illinois, and also Professor Thomas Freur from the University of Nantes in France. And I'm going to pass it over to you guys. Dr. Lieberman has done a lot of research in fast vitrification, fast warming, and some validation of these work. And Professor Thomas Freur has done a lot of work in validation in his clinic. So, over to you.
Thank you very much. It's okay. Thanks for coming. I know it's very noisy, so when you have questions, we can answer that later. My talk is about I want to talk about time, speed and efficiency and new developments in vitrification and warming of oocytes on blastocysts. And my second slide shows you, clinical research on human blastocysts, and on oocytes it's more still research, but you will find more data here at the meeting presented by other groups. I had published both of these recently, as you might follow me on LinkedIn, on RBM Online, on blastocysts and on oocytes. And the next slide just shows you how we traditionally vitrified blastocysts. It took us usually 9 minutes, and now we vitrify blastocysts in 5 minutes. So we do 4 minutes in ES plus 1 minute in VS. And when we come to the warming, our traditional warming protocol needed 11 minutes to warm the blastocysts, and now we are down to 1 minute for warming blastocysts. And here I show you some numbers using Vitrolife media. We fought quite a number of blastocysts, about 90, with an excellent survival. This is a one-step protocol, fought in 1 molar sucrose for 1 minute. And you see how these blastocysts develop after the warming with a nice development in terms of hatching completely or partially. And then I want to show you our numbers from a clinical setting. We have now close to 3,000 transfers. And you see when you go with the positive beta, independent from the age, it's usually consistently over 70%, except for older patients, it's 65%. And when we come to the table that is close to my picture, it shows you the ongoing pregnancy, implantation rate, and finally to take home a baby rate of more than 50% when we use this protocol. So the outcome data are very convincing that this way to force a blastocyst in this very short time is safe. Now I want to come to the oocytes. As you might know, oocyte takes much more longer. It's very time consuming. So the usual procedure is 10 to 15 minutes in the ES solution, then 1 minute in the VS, so a total of 16. And now I cut it down to 2 minutes. I keep them for 1 minute in ES, 1 minute in VS, and then they were vitrified. So from 60 minutes down to 2 minutes. When we look at the warming, we usually warm in 9 minutes. You start with TS for 1 minute, you go in ES for 3 minutes, followed by WS for 5 minutes, and another 1 or 2 minutes in WS. So it comes down to 9 minutes, and my protocol comes down to 2 minutes. I don't start with TS, I use DS, so 0.5 molar, and then I stay for 1 minute, and then for another minute in 2 drops of wash solution. So cutting down egg freezing and warming from about 27 minutes down to a total of 4 minutes. I want to show you just, this is the way most of you might vitrify, and you see how the volume of the oocyte is changing shortly after exposure to ES. It comes down to about a reduction of 60%, so 40% is remaining of the oocyte, and then over time it's regaining the volume. And when you look at the size of the oocyte, the volume, you gain about 80% of the volume back after about 10 minutes. And when you keep another 5 minutes, so there's no change in the volume, it stays at 80, when we plunge them in VS, and you see a drop, another reduction in volume back to 40%. And my protocol shows you similar events, but in just a shorter time. Right? You see also in ES the reduction of the volume, and when we go in VS, you also come down to about 60% loss of the volume. So when you compare the volume, what you achieve after 16 minutes versus 2, it's about 40% of the oocyte, but in a shorter time, you keep the oocyte out to an unnatural temperature, unphysiological conditions, because you do the vitrification at room temperature. So the benefit of a shorter exposure time is also not just a short exposure time, but you reduce the time outside of the incubator for the oocytes. And this is some numbers I did with the Vitrolife medium. That's GV's oocytes, and you see GVs on one side, a consistent survival over 90% as well for metaphase 1 oocytes.
It's the same kit? Or
Same kit, yes. And then you see here some pictures, how they look, right? You know, we almost think they are not vitrified. And then finally, I used a closed system. I think most of you using open system for egg freezing for, you know, the main reason to have a higher cooling rate. But I can show you that the rapid eye in combination with the Vitrolife freezing kit for oocytes works as well. And you see here I vitrified some oocytes, 29 on a closed system. It's a rapid eye. So oocytes stay there because of surface tension on this little hole, and when you warm, you just dip it in the solution and they fall out of this hole. And you see there is a 100% survival even with a closed system. And you see here some oocytes from this, from this attempt. And that's pretty much. Thank you very much. I'm sure you have questions. We can answer them later. Thank you.
Thank you very much for that. We're going to get to some questions after the session. I'm going to pass over now to Professor Frö. Tell us a bit more about your clinical experience, please.
Well, thank you, Jaku. Hi, everyone. Just before I start, I must share with the people connected online that it's a little bit special moment because there are so many people around. I mean, thousands of people, millions of people. So just like Jaku said, there's only Taylor Swift doing better than us. Okay, now I'm going to share with you my experience, my 2-year now experience with rapid warming with the Vitrolife media. So just a little bit of context. I'm the head of the IVF department of the University Hospital of Nantes in France. So it's roughly a middle-sized IVF unit, at least for France. We do more or less 1,400 ovum pickups a year, and we have approximately the same number of frozen blastocyst transfers. And actually, the embryo culture and embryo transfer strategy is 100% blastocysts for every patient, no exception. And we do more or less 95% of single blastocyst transfers. And actually, we culture all our embryos in time-lapse culture because we use the embryoscopes. So, just to remind you, for those who are not familiar with the Vitrolife warming media, here is a short description of conventional warming protocol. It all starts with warm 1 medium for 2 minutes, then moving to warm 2 medium for 3 minutes. All of this is 37 degrees. And then warm 3 from 5 to 10 minutes before moving the embryos to culture medium. So altogether, this is more or less 15 minutes. So now I'm going to share with you the ultra-fast or simplified, as you might wish, warming protocol. So this ultra-fast warming protocol is the same at the very beginning, warm 1 for 2 minutes, and then that's it. Only 2 minutes as compared to 50 minutes with the conventional warming protocol. So it's only warm 1 medium for 2 minutes, and then you move to regular culture medium before embryo transfer. So you save approximately 12-30 minutes as compared to the conventional protocol. So we progressively implemented this simplified ultra-fast warming protocol since 2022. It all started with the first step based on basic experiments, and we used blastocysts donated for research, and we had exactly the same outcome for these blastocysts used for research as compared to conventional protocol in terms of survival expansion. So we were quite confident with that. And we also did some kind of lineage tracing, or we looked at lineage markers of endoderm, epiblast, and trophectoderm, and they were exactly the same that we were used to have with the conventional protocol. So then we moved to a second step, which was some kind of, let's say, pseudo-randomized clinical study comparing approximately 50 cycles with the conventional protocol and 50 cycles with the ultra-fast protocol. And then once again, we had exactly the same survival, expansion after 2 hours, and implantation rates. So then we decided to implement the ultra-fast warming protocol in clinical practice, and we closely monitored the outcome, of course, the key performance indicators, and we were very comfortable with that because within the next month, the next weeks, we had exactly the same outcomes once again, and you can see the numbers in details, and hopefully this is going to be published within the next days. So what is the current situation? So we've been using this ultra-fast warming protocol for all the cycles for about 2 years now. So this means more than 2,500 warmed embryos, and we have something like 98.5 survival rate, and our live birth rate per transfer is on average 28.4. So that might look or seem poor to some of you or disappointing, but just as compared to our experience and to the average numbers and outcomes in France and Europe, this is more than acceptable. And beyond pregnancy and live birth rates, of course, we monitored perinatal and obstetrical outcomes, and there was nothing different as compared to what we had before. And in the end, beside clinical outcome, we could, let's say, reorganize and streamline our organization in the lab, because the very short warming protocol allowed us to implement more warming slots per day. So that means more frozen blastocyst transfers that can be organized every day. And this results, of course, in less waiting list for all the patients of the center. So a few comments before I end up with that. First of all, and this is very difficult to quantify, but let me share with you how satisfied my staff is with this new protocol. They would never change and get back to the former historical protocol. It's more flexibility, more comfort. They can be more, let's say, the organization is more smooth and easy on a daily basis. The workflow is better, and actually this allows more activity in the end and more flexibility, and I would say that it's more or less like time-lapse. I mean, time-lapse, it allows more flexibility in the organization on the IVF lab, so fast warming would be more or less the same for people and the staff working in that field. The outcomes, as far as we know at the moment, are at least maintained, and maybe they're getting better or slightly better, but this is, let's say, not validated yet, but at least the outcomes are perfectly stable. And finally, this is, let's say, reinforced by more and more reports by other teams reporting the same encouraging results. And finally, now we are done and extremely comfortable with fast warming of blastocysts. We are trying to set up the same approach for oocytes and also for vitrification that is currently tested in my lab according to Jürgen's experience. And that's it. So in conclusion, I would say that rapid blastocyst vitrification and warming is a rapidly growing activity in the lab that is associated with a huge workload. But ultra-fast warming protocol, it does result in excellent and maintained outcome and optimized flexibility and workflow. And in the end, this is better for patients and this is better for the staff. So well, what else can you ask for? And it sets the basis for implementing, let's say, new generation freezing program with optimized, shorter, standardized procedures, and for both oocytes and embryos. And I'm done. Thank you very much.
Thank you very much, Thomas. Any questions that you would like to ask immediately to the panel? No? I've got a question that I want to pose to you, Jürgen. Is this the fastest we're going to go? If we look at oocytes and blastocysts, physiology, chemistry, Is this it?
For oocytes, yes. For blastocysts, we can be faster without sucrose.
I fully agree. But maybe we shouldn't tell in a Vitrolife meeting.
Yeah,
The,
but
the
you
other-
asked me.
Yeah, fair enough. The other
Is this ultra fast is applicable for blastocyst and omni as well?
I'm sorry, I didn't hear you.
The ultra fast warming, this is applicable for blastocysts and the media for rapid vit and rapid warm omni, or only for blastocysts?
My experience is with warm blast medium, but I guess it can work with omni medium as well. Depends on the kind of sucrose concentration that you use, but of course it can work with both.
Thank you first of all, and I have 3 questions. One, do you puncture the blastocell before you freeze?
No,
No.
No, we don't.
Second.
Never.
Second. Do you find any difference with the age of the patient, if
No.
they are young or old?
No.
And
no,
the
no
third
difference
one,
observed.
You convinced me already. Why Vitrolife doesn't change officially the protocol?
All right. Do you want me to give an answer right now?
I have to
I'm
cover my
I'm
back,
gonna be
my
in
shoulders.
trouble. I'm
Yeah,
gonna be in trouble.
Yeah, I have to have insurance. You
I
see?
think that Jürgen is gonna answer you.
Okay.
No.
I'm
No,
happy to short my time. I assume all of us.
No.
But we
But
have
what-
to have it to be efficient.
Well, okay. Then let's share. Maybe we can share that Vitrolife is considering having an official approval for the modified protocols.
You will sell more.
Yeah, those are maybe a question I can't answer you right now, but it's definitely things that we'll be working on as there's more and more validation taking place. Any other questions at the moment?
If the embryos were frozen with a different, like sage or different kind of media,
There's
is it
no
possible?
difference.
No difference.
Does work exactly the same.
Exactly the same.
No
Okay.
difference.
Okay.
Because we frequently have some embryos coming from other IVF centers. Doesn't make any difference.
No, sometimes when you freeze oocyte, you vitrify the oocyte, the shrinkage is very slow. It depends on the quality of the oocyte. So it's very slow, and then it's came up slower. So how can you avoid this problem?
So the solution I'm using, and I'm sure you use the same, I don't see that. So when I expose the oocytes, is it 6 or 10 to the solution, for example, the ES solution, it takes them like 30 seconds to reach the bottom of the dish. So oocytes in less than a minute in an equilibrium. So there is no need to expose them longer. So we usually... Maybe, yeah, maybe. But I mean, even, you know, you have 10, 9 of them will behave normally. Now it's maybe one who takes longer. I'm not sure if it's a quality criteria. You will freeze it anyway. You might see it when you thaw. It has maybe less chance to survive or doesn't fertilize. But at that moment, you would not take that egg outside of your freezing because of slower reaction to the solutions. You wouldn't. You know, but there is other stuff, what we heard just recently, AI, where we look at cumulus, make predictions based on cumulus, on oocyte quality. So this will help for egg freezers, that you have information on the oocyte before you freeze it. And then you can say, I will exclude it or include it in the freezing.
Great. Thank you very much, gentlemen. Lovely
you,
topic.
Jakob.
If you have more questions, please feel free to ask it afterwards. But join us for the next session, which will be in about 10 minutes' time. Thank you. Hello everybody, welcome again to another session here at Vitrolife Group Academy Studio. With me at the moment we have Elena Lenarandamakaku from London Women's Clinic in the UK, and she's going to share her experience with us on using time-lapse, but also the new GX media from Vitrolife. Thank you, Elena.
Thank you for having me. Hello everybody. My name is Elena, I'm the head of embryology for the London Women's Clinic. And today I will be sharing, as Jaakko said, my experience with iDAScore, but also with the new GX series media. I have no conflict of interest to declare. Now, I have a very large team. We do over 6,000 licensed activities per year, and I have a team of about 20 embryologists, so it's extremely important to be able to use tools that they assist me to evaluate embryos with the best possible way and help me to stratify them with the best possible way as well. So with an approximate 25 procedures per day and beautiful pictures like these on our embryoscopes daily, I was looking to try to find the best possible solution to do this. And I started using iDAScore since October 2021. I validated it with over 2,000 embryos, and I have been using it for both fresh and frozen embryo transfers. The pathway and the workflow of using iDAScore is super simple, very user-friendly. After you do have the blastocysts reached, then you can open the application of the iDAScore, and then a score can be given uniquely per embryo so that you can prioritize it for usage. I mainly looked at clinical pregnancy rate per embryo transferred, and I did a comparison between before using the IDA and after, and I did this for fresh and frozen embryos. The overall findings was super easy to use, user-friendly, fast and reliable scoring. It definitely did assist us, and we have found a 97% consistency between the iDAScore and the embryology assessment. And it definitely did save us time so that we can focus on other embryology duties and patient care. So the initial validation showed that there was statistically significant difference for both fresh and frozen embryo transfers. It's extremely important to say here that there was, in the period before using IDA, I was not using any other AI tool, and the previous team was not using morphokinetic analysis as such. Therefore, there is a possibility that just the morphokinetic analysis together with iDAScore does make the difference. So post-validation and the happiness of myself and the team, I am now going to be sharing with you the post-validation period, where we looked at 7,241 embryos, 1,962 of them were fresh, and the remaining were frozen. Again, the outcome, clinical pregnancy per embryo transferred. And as you can see here, the statistical significant difference remained, where we have 30% clinical pregnancy per embryo transferred before iDAScore and 36% afterwards. And a similar situation we have for the frozen transfers, where we have, again, statistical significant difference for before and after. And here I put it in a more of a visual way so that you can see the difference. While I was using iDAScore, I was also using the Vitrolife media throughout, so GIVF, GTL, GMOPS Plus, and Embryo Glue for my transfer. But then, since I've heard about the triple action of the antioxidants released, then I moved into the GX series in November 2023. So the first thing I did, I looked at the last 4 months of the data so that I can see how this antioxidant action might affect my results and my KPIs. I could see no difference in fertilization or blastocyst development, but I did see a jump in the ESHRE rates, which to me made me really happy, and I would like to dip further. Something even more interesting, though, is I wanted to see whether the iDAScore ranges were affected in terms of implantation, in terms of clinical pregnancy rate after I have been using the antioxidant media. And I was very pleased to see that there was not much difference for the lowest viability embryos and the highest, but there was a boost for the middle ranges where perhaps embryos needed this extra assistance. Obviously, this analysis is based purely on 400 embryos, so more validation is necessary, but the initial data are certainly very encouraging. And if I put together a little journey with the Vitrolife and the G and the GX series, stratified by age, I could see a massive jump at the younger age, where I went from 44 to 49 to 65%, and 38 to 39, and 40 to 42, and the 43 plus. So overall, IDA score, super easy tool to use. It can give you an objective and streamlined, fast decision making. It can definitely assist us into make decisions about our embryos and the utilization of them. And also the validation was still 97%, but embryologists will continue to have a different opinion with AI. AI is there to help us. So GX series media showed birth to fertilization with ESHRE, but equivalent KPIs with G series. But it did show a significant improvement in clinical pregnancy rates across all ages. As I said, more data are always necessary for further validation, but the initial data are super, super encouraging, and I'm very happy. Thank you.
Elena, thank you very much for that.
Thanks.
One of the points that you made was about your results with the GX media and that you saw an increase in the ICSI fertilization rates. This is quite interesting because we've seen this before in other studies where they've reported exactly the same thing.
Yes.
What do you think is the significance of having those additional fertilized oocytes for the patient?
I think it's absolutely important to have them because this can help with the utilization and the increase in blastocyst formation later on. Therefore, the more embryos you have, the higher the chance that you can have a better selection for embryos and higher implantation.
And I guess as well, we see quite often a trend towards the patient populations getting older and older, so
Correct.
potentially also producing fewer eggs for the cycle, and therefore the importance of a higher fertilization rate is actually very beneficial.
Absolutely.
Then another question on the use of the AI. You mentioned a little bit there about how it was integrated in your clinic. What is the general perception of your team of using AI, using IDA score in the clinic?
Yeah, very easy to use. They really like to use it. Super easy, fast application, fast results. Nice to see a scoring that will help you to utilize the embryos. Very, very easy, very fast, very accurate as well.
And how much
and the results do show.
Yeah.
Yeah.
And how much do you rely on using the score and using your own judgment when selecting the embryo for transfer?
We do rely on the score a lot, but at the same time, always an embryologist's mind and opinion has to be there. This is a beautiful tool, but I don't want it to be used to overcome the embryologist per se. Yeah.
Any other questions at this stage for Elena? Elena, thank you very much. Been lovely to talk to you, and we'll see you for the next section. Thank you.
Excellent.
Welcome everybody to our next session here at the Vitrolife Group Academy studio. Very exciting session now on what is the future of IVF? Where do we go? I have a beautiful panel here today that's going to talk about what we can expect in the future and share their thoughts and ideas. I'm going to pass it over to you guys to make a brief introduction and then I'll ask you some questions. Danny?
Okay. My name's Danny Sarkis. I'm Chief Scientific Officer at Boston IVF in Massachusetts and North American CSO for EVRMA Global.
And I'm Rita Vassena. I'm currently the co-founder of Fecundis, which is a company dedicated to try to improve the results of IVF cycles.
And I'm Mina Popovic. I'm the scientific director of the Eugene Group, located in, well, we're a group, but I'm based in Barcelona, Spain. And I'm a clinical embryologist originally.
Thank you. And obviously all of them with great experience in the field of IVF. So I want to ask you some questions about the future of IVF. The way I see it, there's three very important parts that could change the way we do things. And maybe, Danny, the first question for you. What do you see as the future in terms of our culture conditions, the culture media, oxygen tension, these kind of things? Are there more to be learned, more changes to be made?
Yeah, I think so, because we've been growing embryos in a very similar fashion for a long time now. We've, modified culture media, we've added amino acids, vitamins to the basic culture media we have. I think what will change is the way we culture embryos. We may use different utensils. I think microfluidics it lends itself to embryo culture, which may allow a more dynamic culture condition. Even though we're looking at one step, but I think culture conditions will change to be more dynamic through microfluidics. I think also we've always used water as the basis, so I think viscosity is something we should definitely look at. The environment in the fallopian tube is very, very different from how we do things in vitro. So I think viscosity may be something that we will look at also in the future.
If I can interrupt you there, why hasn't that changed yet?
I think it's ease of use, and I think in our own minds, we culture cells in media. It's all liquid based. It's easy to handle. Viscosity will introduce its own different challenges. But I think, again, microfluidics can handle that also in terms of how we culture things. So I think, a lot of it's things we get used to rather than things that may actually be better. So I think as embryologists, we're very comfortable sometimes in the things we do. So I think, one of the things we should look at is taking people out of that comfort zone. And that's one of the biggest challenges of introducing any new technology. It's getting people out of that comfort zone.
I don't know if you guys experience the same kind of thing when you introduce something new. It's a big step for laboratories, and I think also if you look at developments that happen, for instance, the whole add-on thing. When do you call it an add-on? When is it going to be protocol?
Yeah. Yeah, if I may add something to what Danny just said, that there is also one aspect that perhaps we have not studied enough in the past, and now with new development in how to assay the uterine environment or the even tubal environment, the tubal fluid, there might be some ways of translating that into a composition that is, let's say, more natural or more closer to what would be the natural environment of an embryo, especially maybe around the time of implantation for culture media.
Yeah, there's certainly a lot of work that is going into testing the embryo, testing the endometrium, and creating the right culture environment. And we certainly have a long way still to go to get it right. We've come a long way already, but there's still more work to be done there. If we move on to another topic, we've seen so much changes in technology over the last few years. If you think back 20 years ago, it looked completely different inside an IVF lab to what it looks now. Rita, what is your take on technology and the implementation of technology, and what can we expect?
Yeah, so I think actually as a field we have a very important challenge, which is the challenge of access. So I would look very positively on almost everything that would allow for more access to IVF. And you can look slightly outside of the lab at things like telemonitoring or having cycles done in different conformation, part away from the clinic, part inside of the clinic. Inside the lab, I think part of access will be to streamline and standardize and make and even automate as much as possible what we do. Always, of course, assuming and hoping that this improvement that we get in terms of lower cost of doing the transfer or doing the cycle are in fact at the end translated to patients, of course. Otherwise, access will not really be improved much.
Mina, in terms of technology, it's easy to say, oh, I want this and theoretically this can work, but to actually make it work and make it a system that somebody can use in the laboratory, that's a bit challenging.
Yes,
what is your opinion on that?
Yeah, I completely agree. And as Danny was saying, I think we're very set in our ways sometimes. So actually integrating the technology and accepting it and getting embryologists and clinicians and professionals to trust the technology is also a step we have to work on. So I think it's very important to validate any technology that we're bringing in and work on. Also, as Rita was mentioning, as we automate things and we make things more accessible, to not compromise on the quality as well. And I think the validation will be very important there. So
let's take a minute about automation. There's been it's a big buzzword. What do you think about automation? What is really possible? Because it's easy to say let's automate everything, but can we? What are the low-hanging fruit in terms of automation that you think?
I think there has been some work being done already for automation. So, for instance, automation in collecting oocytes. There has been automation in ESHRE. There have been papers on automated ESHRE. We can automate certainly several at every step of the process. Automation in cryopreservation. We have seen even automation in a way of embryo assessment. We have now the time lapse and so on that in a way is a type of automation. So I think we will see automation at all steps during the process. It will be important to integrate all of that, which will take I think it's a complex process, and I think we're at the start. So I think it'll take some time. But we're seeing automation in a lot of different areas.
Yeah. I think there are some steps in how we do in general in our cycle is done that are at the same time quite delicate, and at the same time they really rely on the skill of the embryologists, and therefore they're more prone to have variability in outcome. Vitrification is the typical one in which two embryologists, both highly skilled at their job, performing the same protocol, trying to do it really the same, they may have quite different results. So I think that's an area where, we have seen it, in fact, since a few years back, that it was approached by automation, perhaps not to the extent that now might be possible. That would be one area. And I think it's a little bit also, this thinking is a little bit the one that is behind the driving for trying to automate ESHRE, because also there is a variability among operators there. If I were to decide what to automate, apart from making first the easy part, I would definitely look for the steps that are more variable and they require more of the embryology personal skills, so to speak, that are difficult to replicate even with training from one to the next.
I think the labs work quite efficiently, and it's interesting to always go into an IVF lab and try to automate things, but I think Rita mentioned before, one of our biggest challenges is access, and access, for more patients, because we only treat a very small majority of infertility patients. So I see automation in actually allowing more access. So, it's easy to get a treatment cycle here in Amsterdam, but 3 hours out from Amsterdam, people don't have as much access. It's even worse in America. In Asia, it's worse. So I think if we can use automation and new technologies to allow patients to do IVF where they are, rather than having to travel into a large city, that'll increase the access and the number of patients that IVF is available to, I think.
Very, very relevant point. And I think going forward from that as well is the whole way that we do IVF. We've listened to talks this morning about different ways of doing vitrification to allow for more time. Do you also see that we can change the way that we do IVF to make it more time efficient, to allow more access for patients?
For sure, the way we do IVF in terms of monitoring, we can allow more access. There's a lot of technologies out there now that allow home monitoring, even sending your sperm into a lab, which, has its own challenges in terms of tracing. But I think all these technologies will allow easier access. We saw with COVID, with telemedicine, was probably the best example that, patients, in the end, our doctors didn't like it at the beginning, but they love it now, and the patients just love that. They don't have to come in for 5-10 visits during, an IVF cycle. They can do it from their home, a lot of it. So I think a lot of that will change in the future.
Yeah, and I think in terms of automation, I think the focus will be, we will really have to go back to how we can simplify procedures. And I think that's the way that automation may also work. And that's what, as you're saying, optimizing procedures, simplifying procedures. But just to add another point in terms of technology, I think there is also a lot of application of technology for improving the patient experience as well. And that'll be a big focus, I would say, for the future. So to provide patients with more information, improve the experience and optimize their experience within the clinic as well.
But what is it going to take for clinics to implement these changes? What do they need? What kind of empowerment or what examples or studies do they need to actually say, okay, let's make this change?
Well, I think technologies that involve patient experience rather than strictly clinical outcome are much easier to implement. They can be tested locally, in fact, and in fact the solution sometimes is local to a certain clinic or to a very relatively small environment. We have heard yesterday, no later than yesterday in the opening ceremony, the commentary, for instance, that women that are undergoing IVF, and if they have some caring duty already with their family, they sometimes delay rather than having, they prefer testing done at home or some sort of monitoring from afar. And that is definitely a matter of access, and it's a matter of improving the experience, because at the end is just one monitoring. It will not necessarily strictly affect so much the result, but definitely will improve access to treatment.
A final point I would like to make is about, and I've picked it up from all of you, is there needs to be a certain level of training and education for the people that are involved in the IVF cycle, not necessarily only the embryologists or the technicians, but for the whole staff group that will be responsible for that. What is your experience, and what do you see we can do better in terms of training and education for the clinical staff?
I think we do a fairly good job with training, but a lot of what we do is very individualised in actually the training. So I think it sort of starts from the home, basically. So, I think clinics have to take more responsibility in training embryologists, I think, rather than trying to steal them from other clinics. And and it's the same with any technology. So I think the industry in itself has to take more responsibility in training, I think, especially embryologists, which is, where you come from. But we probably, I think, in Europe there's probably more embryologists than, say, the US. It's a major problem in the US in terms of finding staff, and that becomes an issue. But I think we have to internally to change our own culture and train a bit more than we do, probably.
And I guess, to a certain extent, if we can improve the future of IVF or change it to optimize the time, it allows us for more training and education.
Yeah.
What do you think about that?
Yeah, no, absolutely. I totally agree, and I coincide with what Danny just said. And in fact, I will go one step further. And I think one of the problem or one of the issue that we are seeing, at least in Europe, but it's getting like that almost everywhere in the world, is that patients, they reach our clinics too late or very close to being too late. And perhaps it's time that we as an industry collectively think if we should perhaps not also train or at least educate our colleagues that see women way before they reach the clinic, and they can channel them perhaps more effectively so that they can get the care they need. The treatment will be probably easier and more successful if they reach, and we all, I think, gain from an improvement in this, axis of education.
Mina, your thoughts?
Yeah, I completely agree with everything that's been said. And I think in terms of implementations of new technology, also really being clear about the benefits of certain technologies and when, implementing a technology, really having the whole team participating in that and, assisting and understanding the benefits to get a technology, put in place and validated and, to include as many people within the team is important.
I think in terms of the future of the technology, we've seen it for a few years now that it's here and it's here to stay. We need to embrace it and make it part of the journey, the IVF journey for the patient to give better access, give them better treatment and better outcomes as well.
Absolutely.
Good. Listen, thank you so much. It's been a privilege talking to the three of you
Thank you.
for sharing your thoughts here today.
Thank you.
Good afternoon and welcome back to the Vitrolife Group Academy Studio, the afternoon sessions. Today it is my pleasure to introduce you Dr. Leire Cordero, coming from Obobank Group in Spain. And she's going to talk about the carrier screening. Dr. Cordero?
Thank you for the invitation, Nasser. On my behalf and also on behalf of the Obobank Group, thank you very much for having us today. And to begin with, I'm going to talk about the carrier screening test and how to optimize your IVF outcomes. Okay, to begin with, as assisted reproduction professionals, one of our main goals is to achieve a healthy child, to help our patients to achieve a healthy child. This is to prevent the offspring from disease. We can do this at the preconceptional, preimplantational, or prenatal level. And to do so, several strategies have been developed through the years to achieve as much genetic information as possible. We have, for example, at a preconceptional level, the carrier screening tests, at a preimplantational level, the PGT, so preimplantation genetic testing, and as a prenatal level, the amniocentesis or chorionic villus sampling. Ideally, one of the main approaches could be the preconceptional level. This is before fertilization step takes place. Why is this prevention I'm talking about every day and all the time so important? Okay, around 84% of the individuals are carriers of at least 2 genetic mutations. Moreover, around 2 to 5% of the couples are at risk of having a child with an autosomic recessive or an X-linked disease. And according to the World Health Organization, 10 out of 1,000 newborns are affected by any of these genetic conditions. So, taking all of this into account, genetic disorders represent a significant impact in our society. And there is indeed the need to identify the risk and also prevent its consequences. The most common are autosomic recessive or X-linked diseases, genetic diseases, according to the WHO, are alpha and beta thalassemia, sickle cell anemia, Tay-Sachs disease, Fragile X syndrome, cystic fibrosis, and hemophilia. At Oboclinic and Obobank, we are very, very conscious about this fact, and this is why we perform this carrier screening to both our patients and to our donors. What does carrier screening do? Okay, first of all, it identifies the individual with a certain mutation or several mutations that can give rise to an affected child. And moreover, it compares the information from both individuals, in the case, for example, of a couple, of the male and the female, and in case of heterologous IVF treatments, as we do normally in our clinic, it compares the patient with the gamete donor, the egg donor or the semen sample donor, matching them and determining the reproductive risk of genetic disorder. Okay. This reproductive risk gives us information in order to help both the clinicians and the patients to consider the most complete range of reproductive options and help us take better clinical decisions. So, the recommendations for this genetic carrier screening would be to any couple who wants to conceive knowing the risk of having an affected child, before an assisted reproduction treatment using their own gametes inside a couple. Also, we could recommend this genetic carrier screening before a gamete donation treatment to test the donor and the patient. And also to couples with a medical history of a specific disease. Okay, if you look up in the internet for carrier screening, you may see that there is a very broad choice of tests. So which one should we choose? I choose this article from 2021 that analyzed, it is a review that analyzed 16 companies that were offering 42 carrier screening panels. And the conclusion they arrived to is that there is a very large diversity depending on the panel. Why? Because some panels analyze from 3 up to 1,577 genes. So this is quite a variability between the panels. Moreover, an overall of 2,673 diseases were screened, but none of them were present in all panels. This means that some panels miss some diseases and another ones miss other ones. So there was no test that analyzed all the diseases. So the conclusion of this paper is that there is still the need to develop a standardized panel for all in order to facilitate later on the matching between the individuals. Okay, at our clinic and Ovobank, as an IVF clinic and also a gamete bank, we perform the 3 CGT options offered by eGenomics. We perform the CGT Plus on our patients, and we perform the CGT bank and CGT exome in our donors to later on facilitate the matching step, but we will arrive to that, don't worry. First of all, CGT test by eGenomics introduce or perform the whole exome sequences. This is, they identify the variations in the exome. Why it is so important? Because it is the protein coding part of the genome, and it constitutes around 1 to 2% of it. And it is so interesting for us as embryologists and also IVF professional because the exome encodes most of the known disease-related variants. So by sequencing the exome, we have an optimization in the screening in terms of time, cost, and efficiency, because we don't have to sequence the whole genome. We just focus on the exome. Okay, this is quite a summary of the available panels by eGenomics. The CGT bank is a panel exclusively performed on donors, and it analyzes 7 of the most common gene variations, that could be, plus 65 X-linked genetic disorders. On the other hand, well, apart from CGT bank, to our donors we perform the CGT exome, which is the sequencing of the whole exome. And to our patients, we perform the CGT Plus, which includes around 170 genes linked to autosomic recessive disorders, plus including the 65 X-linked genes. Okay, here I brought an example, a real example actually, because it's so Clinic Madrid, about a CGT bank that we received from eGenomics, our reports. And what we do is, if the CGT bank, the donor tests negative, it means that she is not a carrier for any of the 7 analyzed genes, plus the 65 X-linked related disorders. Therefore, she is accepted in our bank. If the donor would test positive, for example, for the CGT bank, we could exclude her from our bank, because this means she's a carrier of one of the most common 7 autosomic recessive diseases or X-linked diseases. Okay, as we have talked before, we perform CGT bank and CGT exome in our donors to achieve as much information as possible, as much genetic information as possible, to facilitate this matching step. Why? Because to our patients we perform the CGT Plus, so we have already the whole data, genetic data about the donor, where we are doing the matching step. So the matching is automatically done. We don't have to retest the donor. Why? Because retesting the donor would mean an increase in cost of time, money, and a new blood extraction. So in this way, we already have the whole data. In fact, CGT exome, the data can be upgraded so that we can perform the matching step in a very easy way. And moreover, we don't have to store the frozen blood of the donor. Okay, what happens if the donor and the patient, for example, tests positive for an autosomic recessive disease? So they are carriers of the same autosomic recessive disease. You can either change the donor or go on with the same donor and perform the PGTM on the embryo, the monogenic disease. Particularly, we wouldn't advise to go on and perform the PGTM. What we would advise is to change the gamete donor. Why? Because going on and perform the PGTM on the embryo would increase the risk of a disease, and moreover, it will increase the cost. You have to retest again. Last but not least, I wanted to highlight some aspects to consider about the carrier screening tests. eGenomics CGT achieves a 98% of sensitivity. They have very few false negative results. No test achieves 100% of sensitivity, so we can be sure and we can go on by achieving a 98% of sensitivity. It's quite a good result. Moreover, we only get to know the information about the analyzed genes. We should take into account that if we are testing several genes, we can't get information about the ones that we are not testing. So we have to take this aspect, we have to consider this aspect when performing carrier screening tests. Moreover, as the sample comes from a blood extraction, we can detect the germinal mosaics. And even if the test tested negative for the carrier screening and also we have a favorable matching, a de novo mutation may appear in the offspring and we can't be sure to detect it. And last but not least, I asked this question of a standardized panel for all because you have seen there is a broad choice of tests depending on where do you look at or in which web do you look at. But eGenomics CGT panel allows the universal matching with other reference laboratories panels. And as conclusions of the presentation, we may say that genetic disorders are relevant in our society. We have seen the statistics, the 84% carriers, etc. And therefore, we need to identify the risk and prevent its consequences. Carrier screening should be advised to any person wanting to conceive, and especially in IVF treatments and in heterologous IVF treatments, as we perform in our clinic and Ovobank, it is very important for achieving IVF optimized outcomes. Moreover, I wanted to highlight the point of the need of a standardized universal panels, because nowadays we have a lot of different panels and not all of them test for the same diseases. So this would facilitate the matching and determine the reproductive risk to take the best clinical decisions. And the whole exome sequencing technology from eGenomics optimizes the process in terms of times, money, and easy or efficiency in the interpretation of the results. To finish a little bit with this short presentation, I wanted to highlight that genetic conditions cannot be cured, but can be prevented. And this is what we try every day as IVF professionals. Thank you very much.
Thank you. Thank you very much,
Thank you.
Leire. Fantastic presentation.
Thank you very much.
Is there any question on the audience?
Hi, Leire. Thank you
good
so much
afternoon.
for the presentation.
Thank you.
I wonder if you have followed up the donors that are positive for example, for is-linked condition.
For, excuse me?
Is-linked. Any is-linked condition that maybe you cannot get the oocytes from that donor because there is direct risk.
Okay.
Do you know if they follow a treatment or you have chance to see that? I mean, if donors discarded from the programs because of an is-linked positive result, they go then, I don't know if you have your data, then come to your clinic to follow PGTM or something like that?
Do you mean if we accept them and later on perform the PGTM to the embryo?
Yeah. Something like a follow-up of that result. You cannot get the oocytes to be used for other treatments, but
actually, I guess we directly don't accept them because we are very rigorous about the CGT bank. So we want to make sure that at least in those 7 most common autosomic recessive diseases and the X-linked, they don't test positive for any, they aren't carriers of any condition.
Okay.
I could say so.
Thank you.
Thank you very much.
Anyone else? So, how about this kind of tests are mandatory at the clinic, or what do you think about it?
Okay, for the patients, they aren't mandatory. They are offered to our patients, the CGT Plus, but we highly and strongly recommend for them to perform the CGT. Otherwise, you are kind of blind in the process of the matching step, and it's no use. It increases the cost, time, money, and moreover, the psychological aspect, obviously. So we prefer to offer them the possibility to perform the CGT Plus, and then perform the matching step, making sure the offspring will be healthy. Thank you very much.
Super clear. Thank you very much.
Thank you so much.
Thank you all for your attendance, and see you all in 15 minutes to talk about non-invasive POC. See you later.
Thank you.
Thank you. Hello again, dear friends. Today is my pleasure to introduce you my friend and colleague, Dr. Miguel Vilan, that he's going to talk about non-invasive POC. Miguel, please, whenever you want, the floor is yours.
Thank you. Thank you very much, Nasser, for this nice introduction. And yeah, we are going to talk about this topic, that is the use of liquid biopsy adapted to cases of miscarriages. So this is my disclosure, and I would like to start with these two questions that when it comes to pregnancy losses are very frequent. And the first question is, why this happened to me? And the second question is there anything that can be done just to avoid this to happen again, right? And this is a very important topic because pregnancy losses cause, a huge psychological impact in families and in couples. And it's quite important, and it's been described that it's quite important just to detect these severely affected couples, psychologically affected couples, just to be identified and just to find tools for a proper management so these couples can move on. But when it comes to have these tools and do testing on these couples, no guideline, no professional guideline endorse the use of any sort of testing in isolated pregnancy losses. But this is true that in this specific guideline, is recommended that, is stated that it could be done for explanatory purposes, right? And it makes a lot of sense because whenever it's well described, you can find, a lot of scientific literature regarding how beneficial it is just to find out the etiology for these pregnancy losses, helping to alleviate this psychological distress that this couple have, and helping this couple just to have a proper closure. So, and these pregnancy losses is not a rare event. So it's been estimated that depending on the setting, among 15 to 25%, up to 25% of the couples having a pregnancy may end in a miscarriage. And if these bars represent all the possible factors contributing or causing a miscarriage, there is only one that accounts for more than 50% of all the pregnancy losses, more than 50%. So make a lot of sense that whenever we want to start doing testing in couples just to find out the etiology for these pregnancy losses, that we start doing genetic testing because we are going to save time and money, okay? And this is very important for the couples. But what happened? The situation is that so far, to do this kind of genetic testing, what we have to do is just to get the tissue. And getting the tissue is not always a trivial thing. So many times what we get is a tissue in which we can recognize the placental or the fetal structures, so it's okay. But sometimes what we can see on the right is that we receive a tissue that the vitality is not good enough to do certain genetic testing. And on the other side, we cannot recognize easily this fetal or placental material, and we have maternal cell contamination. And it's well accepted that in general, when we do dilatation and curettage or aspiration or whatever, just to collect this tissue, and we do molecular genetic testing like NGS or chromosomal microarrays, we will have 20% of maternal cell contamination. So 20% of patients not having a result, When it comes to other kind of testing, like karyotyping, we can end with a more than 50% of non-informative cases. So this is our situation. This is the fact number one. And the fact number two is that worldwide, if we think worldwide, the situation is that the most extended practice is not to collect this tissue to do any sort of testing. The most extended situation is just to give a medical treatment, the misoprostol or the cytotec, just for the lady to have this evacuation, induced evacuation privately at home. The reasons behind this, many different factors. Some of them, you can see these factors listed in here. In some cases, the doctors, they don't know how to do the dilatation and curettage, or they know how to do it, but the facilities are not ready just to perform this kind of procedure, so they have to take the transfer the patient to another colleague or another center to do that, which is not convenient. Another factors could be that they don't want to take any risk that is associated with invasive sampling. And the last is that the most standard is that many times doctors, they want a safer environment for the lady just to have this evacuation at home and move on psychologically, right? So at the end, what we have is that the majority of pregnancy losses remain untested. And if you talk with the doctors and patients, and you say, okay, would you like to have this result? Would you like to know if the reason behind this pregnancy loss is an aneuploidy, a chromosomal abnormality? The response is yes. The answer is yes. So we were encouraged by our doctors and our collaborators just to develop this liquid biopsy approach for pregnancy losses, that the name is NIPOC, and this acronym stands for non-invasive POC analysis, product of conception analysis. And it's a simple blood test. So if you are familiar with an NIPT, the non-invasive prenatal testing for ongoing pregnancies, technically is very similar. So what we do is just to draw a blood sample. We isolate the plasma and the DNA, we sequence the DNA, and at the end of the road, what we do is just to analyze bioinformatically all this cell-free DNA that we've isolated with an adapted algorithm. And this is very important. So we cannot do the analysis as per an NIPT for ongoing pregnancies because the intended use and the population is completely different. We are talking about miscarriages in which the fetal fraction is going to be lower and the prevalence of the diseases or the enabling are going to be higher. So this algorithm, this diagnostic rule should be adapted. And this is what we did. We did this adaptation based on the knowledge that we had. So there are several articles in the scientific literature that you can find describing the experience of using cell-free DNA in cases of miscarriages. These latest hours that we published last year in 2023 in the British Journal. And what is clear, which is crystal clear, is that using the cell-free DNA and doing the analysis as per an ongoing pregnancy with an NIPT is not enough. So the sensitivity that we are getting is in the 50s, 60%. So this is quite similar to which we have currently with the karyotype. And we want something better. So it's necessary to adapt this algorithm. This is the validation that we did with our adaptation for this miscarriage population. On the right, you can see that we did the analysis in the tissue as a reference or gold standard, and then we analyzed the cell-free DNA in the blood from these mothers just to see the concordance rate. And you can see how the concordance rate reached the close to 90%. And the sensitivity, and the sensitivity in is not working. Yeah. And the sensitivity and the specificity, you can see that is 90% and 97%. So nothing to do with these 50 or 60s. We go to 90%, okay? Excluding triploids. We will talk about this later. So the benefits are clear. First, it's not invasive, so you don't need any surgical procedure. Second, it's fast. We are releasing the results. Our commitment is 7 working days, but we can release, and we are releasing the reports in only 3 working days, as we do for the NIPT service that we already have. And it's very informative. So if you pay attention to the gold standard in many locations around the world, that is the karyotype, the informativity is around 50 or less, and we are getting an informativity close to 90%. Similar to other approaches, molecular approaches like the NGS or the CMA that you may find in the when you do the studies in the tissue. So obviously, you know the benefits. You don't need to do any surgical procedure. Whenever you want to do this kind of testing, just for explanatory purposes or whatever, obviously, you are going to avoid any kind of risk associated with the sampling. The patients will have just a reason just to know what happened, and will have a private evacuation because they can take this medication after the blood collection at home, and it's safer psychologically. In 50% of the patients will have a reason just to tell and explain what the reason for this miscarriage was. And we will have information for prognosis, because obviously it's much better that the embryo has been arrested because of an aneuploidy, because that means there is nothing to do with the family, with the couple, or in the environment that is not baby-friendly. So it's much better that the reason is the embryo at this point, okay? Regarding the limitations, if you are familiar with the NIPT and this kind of analysis of liquid biopsy in the blood, are exactly the same. The only thing that I want to point out is that the triploidy is not detected with this kind of techniques. This is a sort of limitation. And regarding indications, that for sure is important for you. The indications are clear, so if you stick to the guidelines, obviously recurrent miscarriage whenever you don't have this tissue, okay? The second is obviously if you want to do the testing for explanatory purposes, you can do it in any single an isolated pregnancy loss. But we think that could be very convenient in the IVF population, and this is the third indication, for 2 main reasons. The reason number 1 is because obviously triploidy is a limitation of this approach, But triploidy is much less important in the population, in the IVF population. It's been described in the scientific literature that the triploid miscarriages account only for 1 or 2% if you compare this with the regular pregnancies, in which the pregnancy accounts for 5 or more %, okay? And the reason number 2 is because this could be a new decision-making tool. Why? Because the IVF patient is not a regular patient, it's not a regular couple that they want to achieve a pregnancy. They have a lot of different burdens, starting for psychological burden. Then when they decide to go through an IVF treatment, they have this physical and economical burden to going through this IVF procedure, and then they have a miscarriage. And I recall to the first slide. So now comes the two questions, the two main questions is, why this happened to me, and is there anything that it can be done just to avoid another miscarriage again? And the answer is yes, we can do this kind of analysis that is simple and straightforward. You don't need any facility, a special facility in your centers. It's just a blood test that we can do just to find out if the miscarriage was due to an aneuploidy, and in this sense, what we can do is just to have an interview in the context of a genetic counseling with the patient, discussing different scenarios, just to reduce in the next attempt the likelihood of having a miscarriage, because this is what the lady is asking for, right? Or in the case if normal, we have the opportunity to review carefully this medical record, and altogether, this information is useful because a percentage of these ladies, they are going to become recurrent pregnancy loss patients. And for me, it's totally clear that the management is going to be weaker when you have a recurrent pregnancy loss patient in which the miscarriage number 1, number 2, even number 3, you don't know what the reason and the etiology for this miscarriage is, and you do a management only based on the last one. So based on this information, this genetic information, you are going to do a management, right? So obviously, you can see and you can think that some patients are equivalent, when the reality is that they are not equivalent. And the management could be stronger if we have the big picture in front of us. And it's important, I think it's not only important for the clinical point of view, but it could be even important from the scientific point of view for research. Because obviously it's been described by several authors that it's important just to, whenever we want to do research for certain management or treatments, just to isolate and differentiate which population is with miscarriages, and the miscarriage was due to an aneuploidy, and differentiate this from the aneuploid miscarriages. And why? The reason why is because this could be a confusion. The aneuploidy could be a confusing factor that can be diluting the results. And at the end, we can be drawing wrong or weaker conclusions. So the messages to take home can be summarized in this one. So obviously, miscarriage or aneuploidy is the main factor contributing to these miscarriages. So it makes sense that if we start doing any sort of testing, we start doing genetic testing. This new liquid biopsy adaptation for miscarriages, the intended use obviously is for miscarriages, but it's not intended to substitute all the analysis that we perform in the tissue. Okay, so this is just a complement of these techniques that we already have for those ladies in which the tissue is not available. So now we are broadening the amount of patients that can get this aneuploidy assessment. And the simplicity, obviously, this is liquid biopsy, which is synonym of simplicity, right? So it's simple, it's straightforward, it's accurate, and this could help our patients to alleviate the psychological distress. We can understand better the prognosis for next attempts. We are improving the clinical management. If we know that this is an aneuploid, we can do something in the next cycle, just to reduce future miscarriages. Obviously, we are going to create this perspective for patients that become recurrent pregnancy loss patients, and we are going to improve, in case you are a researcher, a scientist, and you are doing some kind of research, your patient selection in this kind of studies. Finally, let me say thank you to all the phenomenal team that is every day doing clinical and research for this kind of pregnancy loss cases, and that they keep developing new things. And that's all. Thank you so much, and I will be glad to answer any questions that you may have.
Thank you very much, Miguel, for this fantastic presentation. Is there any questions? Because I've got one this morning from a doctor asking when. So what if the patient had a miscarriage at home? Can I do the blood draw few hours later?
No. No, it's been described in one article last year too that it's possible to get the blood up to 12 hours since we have the evacuation of the fetal remains. We don't recommend to do that. It could be done in certain patients with certain characteristics, but the reality is that the cell-free DNA, whenever the fetal remains are outside the body, the cell-free DNA is being released minute by minute. So one of the problems with this miscarriage population or pregnancy loss population is that the fetal fraction is low. It's lower. It's like 50% to the fetal fraction that we may expect for the ongoing pregnancies. So imagine in this situation we are going to have more low fetal fraction if no tissue is inside, so has been evacuated. The cell-free DNA is going to be lower and lower and lower, and the amount of non-informativity should be higher. And the sensitivity, it would be impacted for these low fetal fractions too. This is technicalities, but this is one of the consequences. So we don't recommend to do this sampling, this testing, unless the fetal remains are inside. So the perfect procedure for this should be just to check that is a miscarriage, check that the fetal remains are inside, and then collect the blood before the fetal remains evacuation and before the medical treatment. That we don't know what is the effect and the interaction of this treatment with the analysis. Just in case, until we know this, we prefer not to include these patients.
Okay, perfect. Thank you. Anyone else? Okay, so thank you very much, Miguel, and see you all in half an hour. Thank you. Thank you. Hello again, and today this is the last but not least talk, and it is my pleasure to introduce you my colleague and friend, Dr. María Escrivá, that is coming from Equipo Juana Crespo in Valencia, Spain. And she's going to talk about the 3PN embryos. Maria, whenever you want, the floor is yours.
Thank you. So, hello everybody, my name is María Escrivá, and I'm one of the embryologists in Equipo Juana Crespo in Spain. Okay. First of all, I would like to thank Vitrolife for inviting me to speak about our study that we are currently running in our clinic in cooperation with Genomics. Okay. Today I talk about 3PN embryos and how to manage them in an IVL lab on a routine basis. As we know, in an IVF lab, fertilization, we confirm the fertilization around 17 hours after conventional IVF or ESHRE. Okay. We know that an egg is correctly fertilized when we observe 2 pronuclei and the extraction of the second polar body. This is what we know that we call as a 2PN embryo. Sometimes we observe a third PN, and we know that the egg is it's incorrectly fertilized, and we call to this egg 3PN embryo. Okay. 3PN embryos are commonly discarded due to the suspected risk of being triploid or having an extra set of chromosomes. So the question is, do all zygotes with 3 observed pronuclei or 3PN embryos have an actual triploid chromosomal complement? In 2017, Capalbo et al. Proposed a new way to look at these 3PN embryos. They divided them into 2 groups according to the size of the third pronucleus, and they only analyzed the embryos where they have 2 similar PNs of similar size, and the extra one was a smaller ones, believing that these might have a better prognosis. They even transfer these embryos, and in result they have 2 healthy babies, proving that viable embryos could be rescued from this pool of 3PN embryos. Recently, Genomics has launched Smart PATA Plus, which is a PATA Plus with several advantages. It's a full-in-one test that has 2 extra quality control as cohort check and contamination detection. It uses a combination of NGS with AI algorithms to enhance the detection of aneuploidies. And in addition, Smart PATA Plus has a SNPs analysis to determine the ploidy of the embryos. So this will allow us to biopsy 1 PN, 2 PN, or 3 PN embryos, classifying them as haploid, diploid, or triploid embryos according to the number of chromosome sets. Another benefit of Smart PATA Plus is that it doesn't require parental samples. So in a simple way, we can biopsy embryos that otherwise they would have been discarded. So knowing that some embryos can be viable from this PPM pool, and now having this new technique, we started with this study to compare both types of 3PN embryos. Those where all pronuclei are similar in size, and the other group is the one where 2 pronuclei are similar in size, and the third one is a smaller one. We wanted to compare them to see if they behave in a similar or in a different way. So now here in ESHRE we have this poster, okay, with the data of the 3PNs collected up to January 2024. But to give better evidence of our findings, we are still collecting 3PNs as we want to increase the number of 3PNs analyzed. So today I'll give you an updated version of our research that includes the data of 198 3PN embryos from 185 cycles involving 180 patients, that all of them consented to participate in the study. The study is ongoing in our lab in Equipo Juana Crespo. It's located in Valencia, in Spain. And the 188 3PNs were observed between June 2023 and April 2024. During that period, our 3PN incidence was 1.9% of all fertilized embryos. So the first thing we did was to define both types of 3PNs. The first group is the microtriploid, or the commonly known as 2.1 embryos, where the diameter of the smallest pronucleus is less than 70% of the diameter of the largest pronucleus. Okay, this is an example of a 2PN embryo, where we see at the right the small PN. Yeah. Well. Okay. These 2.1 embryos might be difficult to identify. So according to our experience, with embryoscope, it's much easier to spot this small PN. As sometimes you have dark or granular areas where it's difficult to spot. Or sometimes, like in this example, at the time of the fertilization check, the small PN hides behind a large PN, so it's difficult to spot it. But with the embryoscope, moving forward or backwards, you will see it eventually. In addition, with embryoscope, for a study, you have more robust data. The second group are the pure triploid, or the PT group, where the diameter of the smallest prenucleus is more than 70% of the diameter of the largest prenucleus. This is an example of a typical pure triploid, and these ones are very easy to identify. Okay, so we'll start with the results. From the 198 free PNs observed, 89 were 2 PN embryos and 109 were PT embryos. All of them, both groups, the 2.1 and the PT, were cultured until blastocyst stage, and as a result, we have 72 good quality blastocysts. We define good quality blastocysts as good enough blastocysts that are suitable for freezing after a potential transfer after analysis. Sorry. Okay. Out of 89 2.1 embryos, 34 reached the blastocyst stage, and out of 109 in the PT group, 38 reached the blastocyst stage, resulting in 38.2 of blastocyst rate for the 2.1 group and 34.9% for the PT group. Not significant differences were found between both rates, but both rates were significantly lower than the blastocyst rate for their sibling 2PN embryos found on those 185 cycles, which was 58.3%. All 72 blastocysts were biopsied, and 60 of them were informative for ploidy and aploidy status, 30 for the 2.1 group and 30 for the PT group. We have very interesting results about the ploidy status of the embryo, as 27 out of the 30 blastocysts in the 2.1 group were diploid, and only 3 were triploid. As 0 in none of the embryos in the PT group were diploid, and all of them confirmed to be triploid. So the diploidy rate is 90% for the 2.1 group versus 0% in the PT group. We are fully aware that 60 cases may not be enough to draw strong conclusions in a PhD program, especially due to the heterogeneous dispersion of the age of our patients. So to simplify this, what we wanted to do here was to compare the euploidy rate of our overall free PNs with the euploidy rate of our overall 2 PNs biopsy during 2023. What is important here is to observe that not only that a euploid population among free PNs not only exists, but is also similar to the 2 PN group. And we're sure that we will reach a more solid conclusion as the number of free PNs biopsied increases. Finally, we have the rates for the viable embryos in each group. For the 2.1 group, out of the 30 embryos, 27 were diploid, and out of these 27, we have 10 viable embryos for transfer. Despite having euploid embryos in the PT group, as none of them were diploid, there were no available embryos for transfer for patients. So 33.3, or a third, of the 2.1 biopsied embryos are viable embryos for transfer for patient. So as a take-home messages, we can say that it's very important to differentiate the two types of the free PNs, because they will help us to know the potential of the embryo and advising the patient in the best way. Most of the 2PN the 2.1 free PNs are diploid, 90%, so it is worth to biopsy and analyze them using PAT+. because with this technology, they will inform us about the ploidy and the euploid status of the embryo. Despite most of them being diploid, the remaining 10% of 2-point embryos are truly triploid. So we cannot transfer them without a previous analysis, as they could result in miscarriages or triploid pregnancy or molar pregnancy. Regardless being triploid or diploid, embryos could be still euploid, mosaic or aneuploid. So with PET+, we will know if they are suitable for transfer. A third of the 2.1 biopsy blastocysts are viable embryos, increasing the number of viable embryos available for the patient for transfer. So as a conclusion, we can say that despite having a lower blastocyst rate than 2PN embryos, micro 3PNs or 2.1 embryos are worth to be kept and analyzed. It's very important to be analyzed, as they are very likely to be diploid and their euploid rate is similar to 2PN embryos, increasing the number of transferable embryos as a benefit for patients. And thank you very much.
Thank you very much, Maria. Congratulations for fantastic presentation.
Thank you.
Is there any question on the audience? Come on, don't be shy. So I've got one question. Do you think that this kind of test is going to be the standard of care in the near future at the clinics? Because we have more embryos to transfer, but also avoiding transferring euploid embryos that are triploid or haploid, right?
Yeah. My opinion, 100%. But not only for triploid, even for 1PN, 3PNs, both types of 3PNs, even a 4PN or 5, because it's very easy with this test. It's just a routine analysis, a routine biopsy on blastocyst stage, and you will get the results, and you can give an extra embryo for the patient. And I think it's especially important for this patient with low reserve, avoid that all patients, that the number of embryos are very important for them. So an extra embryo is always a very good news.
Yeah, we know that. Okay, so if you don't have any more questions here?
Hi, so nice presentation.
Thank you.
I'm Jorge Gomez from Finland. Do you see like any difference between like the rates between ICSI and conventional IVF?
No, we haven't seen. We have all this data is collected from ICSI, as they are in embryoscope, and we are just collecting the data from embryoscope. But we wanted to be them on time labs to have more robust conclusions, and then we will see even the kinetic parameters of the embryo. So they are in time labs from the beginning. So we have only ICSI for this.
So
sorry.
All this data is from ICSI.
It's from ICSI, yes.
More questions? Okay, so thank you very much again, Maria. Fantastic presentation.
Thank you.
And see you all tomorrow on the second day of the Vitrolife Group Academy Studio. Thank you.